Thank you again for being here.
Absolutely. Thank you for everybody coming. There's nothing better than walking into that auditorium and then seeing Misha. The two of them, I don't know, they pretty much compare. I love it when you drive by and you stop in Wilmington, Delaware. We actually have the best time. We realized that we would actually be best friends had we not had so many miles in between us. Yes. So I was tasked with talking about the HIP and AMC, kind of the easiest problem to deal with, not. But we always have to put a disclosure slide. I talk for some people, but that's about it. But first of all, happy 4th of July. And so hopefully you guys are going to have a great time here in Atlanta, Georgia. I'm traveling back up to Cooperstown, New York to be with my family tonight. So hopefully I won't miss the fireworks there. So I have a couple of objectives. I always talk about the patient and their family really needing to be a big part of the team. So my first objective is let's get down and dirty. Let's talk about some of the medical jargon that comes around the hip. Let's give you some terms that you might be able to play with so that when you go in to talk to whomever you're seeing, a physical therapist, occupational therapist, orthopedic surgeon, that you kind of have an idea of what they're talking about. Because I know some of these conversations go whoop, and honestly, if we had perfect answer, we probably wouldn't have to talk about this, but we don't. Everyone's a little bit different. You can see from just the crowd of people here, no two people look identical, but most, there are some similarities and differences between each one. I would really like to give you sort of insight into what am I thinking when I'm planning surgery. I think that's an important idea to get the flip side. And then maybe give you some goals to help you prepare for your journey and help you navigate that. As you can see, some of these patients, I have disclosures for all of them to be shown in these pictures, but they're amazing. That video upstairs about the superheroes, like she just had hip surgery and look at her, it's crazy. But the hip, the reason why we're talking about it is obviously we all know that there are, it's involved a lot of the time. So we see contractures in the hips almost 90% of the times, especially in amyloplasia. Hip dislocations are also quite common. They can be unilateral or bilateral, and there are different ways to treat that potentially. So alone, we can do so little. Together, we can do so much. So this is a journey, a team. I have a brace for the race. It's September 21st this year. We have a Ninja Warrior course that's designed for absolutely everybody to participate in. And we're lucky to have Misha on her road trip to stop by, and Rini, one of my physical therapists, and Mike, he's not really dying there. I wish he was here to see this picture. So what is important to bring from to an appointment? Let's start with the very, very basics, because you want to get everything out of your time with your healthcare providers. In our clinic, we have lots and lots of people in the room. We have OT, PT, and I'll show you our team in a minute. Make a file with your child's information, because it's impossible to remember everything. It really is. I mean, I thought I could, after my ACL tear, I thought I could remember when I took Tylenol last versus ibuprofen. Wrong. I completely forgot. I'm like, okay, well, now everyone's going to have to keep a journal. But keeping a file with all of your stuff as you travel, because your journey may take you from one person to the other, and that's absolutely okay. You need to be comfortable with your journey, and this is a journey. There are things that are going to change with your relationship. There are things that maybe one group does a little bit differently and you want to get different options. That's totally fine. Genetic testing is really important. Things change year after year after year. We get more information. So don't, keep what you have, and then be, I think, open if you, especially if you have a person that is really interested in some of these rare diseases. So we're finding out a lot of information. I think we haven't even started on that journey. Bring your studies on a disc, because the reports don't matter. Surgical reports, bring all of your braces, the ones that you love, the ones that you hate, and boy, get a list of questions, put us to the task. All right, so everything is important about your child when we're dealing with a problem that affects from head to toe in some situations, and maybe sometimes just toes. All right, so here's our team, and I am sure that most or a lot of people have sort of this team, and it may not be all together like us. This is really slow, sorry. But we have occupational therapists. The top group is in my clinic every arthropodic meeting. We have Gait Lab. Genetics, she's doing more telemedicine now because she's splitting time in New York and in Wilmington. We have a prosthetic shop in the group. Neurosurgery, neurology are at a phone call away. We have a new integrative health, ortho spine. I have a second partner that does hips all the time, so I really like to get more eyes on the prize. Social work, cast techs, and of course my work wives. I have a PA and an MA that are with me all the time, and I can't really give them a good description by saying, oh, she's my PA. No, she's my everything, and so is she's like an MA, scribe, everything. All of these people together make for great care. And sometimes you don't have the fortune of having everyone in the same place, but that doesn't mean that another place doesn't have all of those resources, just more spread out. That's fine. Just learn how to think about all the things you need. Because I can tell you, I see two people in the room that I know well from the arthrogryposis world, and we are all thinking the same way. It's taking care of that patient from a holistic approach. So you need to figure out what your treatment goals are for your child. We need to figure out what our treatment goals are for your child. And then we need to come together, communicate about it, discuss our concerns, our successes, things that we just think that you're doing just fine, even though that knee doesn't bend more than 30 degrees. It does not hold you back. So do we have to do surgery on it? Absolutely not. Maybe it's affecting your hip. Maybe we have to think about it. But just remember, it's not a one-stop shop. All right, so you also have to bring in what life events are happening. Is someone going to kindergarten, first grade, second grade, about to graduate from high school? I had one recently that was the valedictorian of his class. Not surprising. He wants to go to law school, and the only thing he wanted to do, if I did surgery on him, is he wanted to walk, actually without an assisted device, across the stage. And so we had to plan for that because we had to do both sides. And you know what? I couldn't believe it because he was a little bit worried in the beginning. The first cast change was not his favorite. And somehow he made it. He was valedictorian. He gave his speech and he walked across that stage. So that's a huge win for me. So these patients to me bring the most kind of elevated joy in terms of watching their successes. So I never say never in this clinic. So let's get some definitions going because I do think we need to level the playing field. You guys don't have to spend every single night reading like I do about orthopedics. That's my job. That's why I signed up for this. So maybe I can tell you a few things that will sort of get you through. All right. Anybody know what this is? A pelvic x-ray. Perfect. You knew that because you've been watching Grey's Anatomy, so you're fine. Okay? So just a couple of things to know about this. The hip is a ball and socket joint. So the socket is formed by the acetabulum right here. And the ball is somewhere in here. And I'm going to show you something interesting. Okay, I want you to think of this peach. We're in Georgia. It's perfect, right? Okay, so here, oh, shoot, nope. So here we see this is called the ossific nuclei. It looks a little bit like the peach pit. Around the peach pit is delicious fruit. Well, this is, I wouldn't call cartilage delicious, but this is a cartilage. And if you use your x-ray vision, you'll see that there's sort of a white shadow. And this is the acetabulum on this side. This is the ossific nucleus. That means that's where the hip is growing. The ball is growing into the socket. This socket is kind of more horizontal. This socket, very steep. This ball, or the peach pit of the ball, very small. That is concerning that something is going on here. And then, so when you hear the word Shenton's line, now you guys know, this is this really cool arc that's formed by the obturator and the femoral neck. So it makes this really nice congruent shape. Something's wrong here, okay? So you don't have to be an orthopedic surgeon, but you could probably look at this x-ray and say, I do not think that left hip is right. Or maybe the left hip is fine and the right hip is not, but I think intuition sort of tells you, yikes, that is funky. And that means that the peach is kind of moving out towards the lateral side, we think. This is a two-dimensional image. All right, so what our job is to figure out how do we fix this. So this is an adult pelvis. This is just sort of an illustration just to show you that we have some parts. We have the cartilage, which is right around here. It's that nice cushiony part. And then we have a labrum, which holds that femoral head, the ball, into the sockets. That's important. And then we've got some synovial fluid that makes there be little friction until something happens. So it's like ice on ice so that joint can move. And that's really important that a joint moves. Unfortunately, in arthriposis, it doesn't always move so hot. And then the capsule is sometimes tight in the wrong places, and it surrounds the whole thing to keep it in a nice package. Ooh, okay, so I would be remiss if I thought that just, hopefully this will work. We just talked about these muscles, and so each of these layers of muscles are things that I have to worry about, and I'm not going to test you on this one. But I also want you to know that underneath those muscles are huge nerves and arteries and all the scary stuff that you really don't want to learn about because those are scary. So things can go wrong or right in many of these different places. Things can be tight, like that's one of your adductors. It holds your hips together. And even the external rotators can be very, very tight, and the gluteus maximus and medius. So we have to kind of put all those pieces together. So then the next words that you may hear when you have especially an infant, is dysplasia. And that means that there's a shallow or undeveloped socket at the acetabulum, which you all know now what the acetabulum is. And so this is just a nice picture of this, of how, sort of the continuum. Here's that hip. It's beautifully in place. This one, this is not quite as well covered. It's a little bit more shallow, a little steeper looking. And then we move down to subluxation. The hip is starting to slide out the side. And the question is, can we save that? Can we get it in? Or do we have to do some extra work to get it to stay in? And then dislocated, which unfortunately is where a lot of AMCers live, is a more difficult hip to take care of. It's been dislocated since in utero. It's high riding. Another word that you can really shock your care practitioners with is, oh, do I have a pseudoacetabulum? Meaning that the hip has been out and it actually forms a new socket for itself. It should be down here, but it says, I'm going to hang out here and make it look nice. So that is unfortunate. I'll hide that for a second. So a teratologic hip, I'll just tell you that I didn't know this, and maybe I should have, is teratology is the biologic study of monsters. So these hips were obviously hard. They're hard. It doesn't just happen in AMC. It can happen in spina bifida, some other syndromes like Larsen syndrome, neuromuscular conditions, but that's okay. Tough situations build strong people, and I haven't met somebody not strong in the AMC community. All right, so now let's get to the physical exam, and this is sort of an abbreviated thing, but as I'm seeing, whether you're an older child or an infant or somebody really cute right back there, I'm always looking from head to toe, right, Sarah? We look at your head and then your toes. So it's really important because you can be affected in all places, and including your jaw. And I think I wasn't paying attention enough to the jaw in the beginning, but now I have a plastic surgeon that's very interested in that. So everything needs to be stretched. And I just had 2 children that transferred from our NICU onto our floor. And it's so interesting to watch the education that needs to happen. Touch, touch, touch. Every time you touch that child, every time you move your fingers, you're still doing your exercises every night. So these things are really important to me. And I've heard some physical therapists, not in the one in the room right now, that, oh, I can't make you better. And so the patient comes back to me. I'm like, you don't have to make them better. You have to help them with their ADLs. You have to make sure that they're maximizing what they have been given. So there's a variety of physical findings that we can see, and we do need to pay attention to all of them. As I'm looking at the hips, I'm also looking at the knees, I'm looking at the ankles, but more importantly, I'm looking up the chain. Because if I start fixing that hip and that spine is sort of getting away from me because the spines kind of jump in and ruin what you're going to talk about. Are you going to talk about the spine today? Okay, so I trained him, but not in spine because I don't like spine. So hopefully he'll have some really good stuff to say. But we have to keep all of these pieces together. Sarah Nossoff is talking about the lowers. What are you talking about? And so we've got all the people, 3 of the 4 people in the room, but we're going to all talk about a part, but we're really all in communion together because you can't separate each part. So in the hip, you have varying degrees of severity. You can have unilateral hips, bilateral hips. Another piece that you're going to now take to your doctors and say, oh, well, how is my triradiate cartilage? Is it closed or open? So the triradiate cartilage is actually the 3 bones of the pelvis, the pubis, the ischium, and the ilium, all coming together. And it doesn't show up, but this is the growth plate, and it doesn't show up on x-ray because it doesn't have calcium in it yet. And that is really important because that tells me that there's still growth potential left in the acetabulum. And that usually happens to about age 8. So in some cases, when you might have a hip that's subluxating, your doctor's not like, let's go to surgery yesterday. We might ask why, and then you'll think, maybe there's some development that still is happening, and maybe we can do some other things first. So just an idea. All right, so the most common position is probably here when you have flexed and abducted and externally rotated hips, but you do see some of these where they're hyperflexed and the hyperextension of the knees. Hyperextended knees are a little bit more difficult to take care of than flex, but they all have their challenges for sure. So on our physical exam, we're really noting symmetry, and I think that most of you can contend, especially if you have arthrogryposis or not, you might have but I'm going to stick with the AMC group. You might have one side that's your really strong side, and you use that most, and the other side maybe helps you stabilize. You'll see some asymmetry. You might see asymmetry in your pelvic obliquity, your range of motion, your strength, and I'm going to keep pressing on this. I have to check everything, not just the legs. I look at hip abduction, and you can do these studies for every single joint. So, but in the hips, I'm looking for abduction when you bring the legs apart, adduction when you bring them together. I put you on your stomach, on your back. I look at rotation, because rotation in arthrogryposis is very interesting to me. And if you're stiff in your hips, you may compensate with your back. Well, and you can see she's sort of standing with a little bit of knee flexion. This is the same one that was doing a handstand in the beginning. And I thought this was a nice example of her just increased lordosis here. Now, if you have compensation through your spine, but you have scoliosis and you're going to do a spine fusion, then you have to think, am I going to take away your sitting ability by stiffening your spine, and sometimes vice versa. So it's tricky. That's why I say it's not one-stop shopping. You've got to look at the patient and touch the skin and the soft tissues and understand where you are there. So with a baby, this is for general dysplasia too. We actually look at the gluteal creases, and you see if they're symmetric or not. This is a good sign that there's something going on in the hip. This is if you bring, now not everybody can flex their knees, but this knee is shorter, and so that means that the hip is probably slipped out the back. This does not show the asymmetry of the gluteal folds, but it does have some asymmetry of the thigh folds. Now that is not quite as clear an indicator, but can be. So then we look at strength, we look at reflexes, we do see what you can use and what you own. You might not be able to determine that as a baby. Rini, who's sitting in the back, this is one of my favorite things that she has shared with me, is about predicting the future. It's not a perfect graph, but it really does get you sort of in the mindset of, hey, if you have these muscles, or if we can get you to have these muscles, maybe we have to really work with therapists to be very active on your gluteal muscles. Can we get you to stand? Can we get you strong enough that you can support your body? But remember, standing is great, walking is great. Being able to sit in a wheelchair is really important long term. So if you can't sit, then we have to really balance out whether sitting or standing is more important. So we also have a very renowned gait lab. So I do a lot of evaluations with gait lab because I think there's a lot of rotational components to this. When they've been treated for club feet, the tibias are actually often very external, even though the foot's internal. So we can do a lot of testing and a lot of outcome measures from there. We have our little gait lab, and that just makes me laugh. And then we collect a lot of imaging. So this is kind of neat. This is an X-ray where the beam is coming down. This is the triradiate cartilage. Here's the femoral shaft coming in. The head would be here, which is not ossified yet. And this is a schematic of it. And then this is an ultrasound. So when you're a baby, I need to know more information. There just isn't I can't see very much because there's a lot of cartilage. So this is the ultrasound rendition. And if you turn it up on its side, it would be like a left hip. So this is the femoral head, this is the femoral shaft, and this is in the acetabulum, and this is the ilium, which is the bone up here. So kind of cool. So the ultrasound gives us some dynamic measures. So if a hip is in but lax, I can see it coming in and out. So that can help guide my treatment. And we can do that until that peach pit is too big and it doesn't allow those ultrasound waves to go through. So this is a big person. Since you guys are all brilliant with this already, you know that this ossific nuclei looks a little smaller than this one. This acetabular index, or this angle right here, is much bigger than that, so the hip can just slip out. And then you might have noticed that this distance here is much farther than this, and this is up, not down here facing your triradiate cartilage. So that's not a happy hip over here. And then we draw some other lines, and you already know about Shenton's line because you're brilliant about that. And we might talk about Hilgenreiner's line and Perkins. Maybe we mentioned that, and you'd be like, oh, I totally know what that is. So this just gives another indication of where we want this hip is to be sitting right here in the inside corner, not coming towards the outside. So with other imaging, we can do a CT scan that gives us a three-dimensional view of the pelvis. It tells us where the insufficiency is in the acetabulum, and with some other CT studies, we can check the rotation, which we call version in some cases. It is higher radiation. Most pediatric hospitals really are try to modify their dose, but it gives us a lot of bony information. Doesn't see the soft tissues as well though. So an MRI has that advantage. It shows us the soft tissues very nicely, still gives us a three-dimensional imaging. And then we have some sequences that we can use that look at the growth plates and the cartilage very nicely. And we can take either one of those modalities. We're a little bit better with the CT scans, and we can make 3D models. So this is one example of a 3D model that we brought into clinic. And we can show sort of this is the epiphysis, or the end of the ball when it's still growing, and kind of looks creepy when you take it all apart, but you can show families that and show them how it articulates into your acetabulum and if it's healthy or not healthy. And this is actually an example. This is the cartilage, so it comes up blue, and this hip is facing you. And it should not be popped out of the joint and facing you. That's bad. So this was another thing that we used to kind of pre-plan. So when you've done your physical exam, you've gotten your imaging, you've gotten maybe your gait lab, depending on how old the child is. What's next? What do you do with all this information? And that's when you hope that you're going to work with a team and make good decisions. So I think about future function. Most importantly, I really want you to be able, ideally, to sit and hula hoop or stand. But sometimes there are trade-offs. So that is a really hard decision. I do my best to maximize both, but I really don't want to take away both. So that makes me think a lot, way too much, actually. So as I alluded to before, in the beginning, when you're trying to make these decisions, you don't have to jump in right away, but maybe this newborn time is the time that we need to be talking the most. Touch, touch, touch. Start to do motion. Try to get things to loosen up, and they do loosen up. You will never look as complicated as you did as an infant with arthrogryposis. It gets better, and that's really important to remember. So I always say kudos to the parents, because I think that they're doing a lot and they just don't even realize how much effect they're having. On the floor this week, I was like, I don't care who's touching. Let's get everybody touching. All the volunteers, just don't touch too hard. Just touch, move the fingers, touch. I think that's critical. So in this time, we might be doing some therapy and splinting and casting. And then, sometimes we cast everything, this poor kid. So we may do a hip surgery at this time would be pretty good. But as they're transitioning, you have to know the patient. You have to know kind of what the soft tissues are doing. Is the hip trying to be okay? Lots of things can happen. I always joke that this kid, he's like a parkour guy. This is a long time ago, but he was 18 months riding that scooter. My typically developing child could not do that, and he was, in hyperextension or hyperflexion when he was born. So really timing your surgical intervention is more of an art than a science, I think. There's really literature to support, get in there fast, put the hips back in, or take your time. But the end result for me is I want function, and I want good alignment for when you want to ride your horse, because that's your end all be all. If you want to cook your dinner, and if you want to be the prom king. So sit, stand, and eat. all important things besides going to college and becoming a music therapist so that you can help people like yourself. And then if you see, there are a lot of people in wheelchairs, and that's fine, but we need to make sure that they can still get into the wheelchair despite our interventions. And that, I do think that's a very hard decision. But maybe it won't go back. One of the other things that yeah, there we go. Nope, now it's gonna listen to me. Perfect. One thing excellent. One thing I think is very important is that when you're older, you need to stay in shape. You need to use what you have, eat healthy, take vitamin D, stay active, because you want your bone health to be as good as possible. So now what do we do? Now, you're looking at me like, oh my gosh, are you going to fix something someday, or are you just going to talk about it? So I was clearly talking to him that I was going to make some difference for him. Arthroposis is not a one-size-fits-all, and I do believe that surgery can improve things, but it is not the cure for arthroposis. I think we have a long way to go with that, but I do have some good news in the end. So our treatment options, we can start with the physical therapy, bracing, and then I'm going to get into some of the procedures that we do to help these. So I did a lot of reviewing literature out there, and the literature is just, I don't know, it's not that helpful. You can do what you want. So she's an amazing kid. So she had hip surgery, but we did start with her feet and her knees first to get her up. Then we did hip surgery. And then, of course, what I would do 6 months after hip surgery is I would be able to do this, because why not? But if you have a unilateral dislocation like she did, I also had to be very careful that her spine was still good. I needed to put that hip back into place, because if I left a single hip out, I know I'm almost guaranteeing they're going to take a trip to Dr. Arun over there. And I don't really, if I can avoid that, I will. That scared me, but I got back. So sitting in balance too, if you're off kilter, it's really hard to position in a wheelchair if you need one. So those are the things I'm thinking. If you have bilateral dislocated hips, that's a whole nother conversation. I think hips want to be in the socket if the socket exists. So there are lots of caveats that go into whether or not you do this. And do you have some other medical conditions that may preclude a very big surgery or two? Because sometimes you can't get both hips in the same setting. Those bilateral dislocations, they do have a higher risk of complication. Subluxation, which, remember, you guys know this term, it's not all the way out, but it's heading in the wrong direction again. Some of them dislocate again. We actually, in our institution, get an MRI afterwards to check to see that. And then in 2 weeks, we get another MRI in the spica, because these are usually young kids that I'm talking about, to make sure it's still in. That 2-week mark, if it's in, you can breathe a little bit of a sigh of relief. AVN, which is called avascular necrosis, is the thing that we really would prefer not to have. See this flattening, this looks like a pretty hip. This is your growth plate. This is beautiful. We love it, nice and round. And this one is flat like a pancake. So something happened to that hip, and it happens more often with, I think, in these teratologic hips, which is unfortunately common in arthroposis. So what are our surgical options to get the hip in? Well, closed reduction is not that successful with arthroposis. Typically, once in a while it happens, but especially if you release some of the inside muscles that are holding the hips together. But pretty much I assume that with a hip dislocation that I will need to do an open reduction, and I will most likely, but not always, have to do acetabular surgery, but I may not do that in the same setting if I think there's enough developmental time. Now, we could get crazy, and this is not a bad choice. Claire et al. Said traction was great. It really prepared those hips, but I just can't do that. We do it for some spines at our institution in halo traction. I haven't gotten there. Are any of you guys using traction? I don't know about you, but I wouldn't want to sit with my child while that was happening. It's just yuck. But it does do good things. Anyway, so let me just talk about some of the procedures. A hip arthrogram is when we inject dye, because remember, it's cartilage, it's the peach, it's the fruit, and you can't see it. So we put some dye in there, and then we can see the morphology of the acetabulum a little bit better. And it gives us a lot more information that, we may have gotten most of that from an MRI if we ended up doing that, But sometimes we don't want to get an MRI of those infants because if they're not in a cast, we have to sedate them for it because it's a longer test than a CT scan. So this does give us some information. It helps tell us what is blocking us from getting that hip in. Is there a lot of fibrocartilage or fatty tissue inside called pulmonar, or is there a tight muscular capsule? So here is an example of an open reduction. So again, you know, this is your triradiate cartilage where all those bones are coming together. That will get in adults, that will become just solid. This hip is, it's okay. It's pretty shallow, this acetabulum, so it's not seating in and facing this triradiate. So we're going in with some scissors because we're going to take out one of the ligaments called the transverse acetabular ligament. And then, it's looking a little bit better. But you know what? Remember, see how this is the acetabular index. This is cartilage in here. This is too high. So there's really no place for that to hold down. So we can make that happen by bending that bone down over the femoral head. And so we do that with all sorts of fancy tools. And this is the bone wedge that's in there. And now, if you look, there's your ossific nuclei, your peach pit. It is facing the triradiate cartilage, which makes us happy. And this bone will become part of her pelvis. So in arthrogryposis, in the older children, it's sometimes you have to do more because the hip doesn't just want to slide in. It's been out for a long time. Those tissues are really tight and holding them out there. So this is another example. This is a little bit older child who, the first day, we at least got them up standing, which was really exciting. But there was not a part of this child's body that hasn't had some kind of effect from arthrogryposis. The hips are dislocated. You can see they're wide and outside. Here's the triradiate cartilage. Here's that femoral head. That should be down here, but there's your pseudoacetabulum, kind of found its own place. And these knees, this should not be gapping like this. That's not that great. The feet had had surgery before. And you know, when I meet you the first time, I'm not going to hopefully say, I would like to do 16 different surgeries. That you really do need to establish a relationship. Sometimes time is of the essence, but you know, hopefully you can have a conversation. So the first thing he did was he went home because he just learned to stand that very day. And then he came back in a few months. They live kind of far away. So they came back, and now he's 3 and he can't sit. He can basically lie down, but he can stand. And if you felt in his groin, you would feel a very hard, round-like bump. So that was his hip dislocating anteriorly, which is a little bit more unusual and very difficult. So these are bilateral dislocated hips that I'm like, oof, now we got to do something, because he cannot sit, he can stand, but lying down in your office is probably, it's not the best position to be in. So I don't know if you'll be able to see this, but this is as far as he can flex. This is the femur, it comes up. His knee is the motion is not perfect. He can't flex more than 90 at this point. So we took one leg at a time. You know, you can only do as much as the patient can sustain. I do like to get as much as I can done in a sitting, but it can be challenging. Are we okay? Are we in trouble? How many? 2 minutes? Oh, fantastic. I'm right on time. No. So anyway, we put this one in. But in this case, if I just put the hip in, we would really cause avascular necrosis. So you can see this is the shaft of the femur, and this is the top. This much was overlapped just by the tension. So we don't want to just push it in, otherwise that would be a problem. So we have to cut part of the bone out, and that's called a femoral shortening, and that basically makes the muscles longer and less space occupying. So hopefully we can get that hip in, which we did, and the range of motion was improved. But then we have to do, we talked about an MRI. So I'm going to skip through this. So I wanted to talk to you a little bit about some of these, when I was telling you about how these, we do this bony work. There are all sorts of names for these. Every time we cut into the bone at a different angle, we try to name it something new. So that's called a dega. This one's a little different. This one causes the hip to come out posteriorly, the acetabulum to come down posteriorly and laterally. So we can cut the bone in the pelvis in a little bit different places to make it work a little bit better. So this is that triradiate cartilage. You see the 3 bones coming together. That's kind of neat. So this is, I'm gonna take 2 extra minutes because I want to just get through this last case. So this is another child, came early. This hip wasn't doing great, but he was doing great, and we wanted him to be strong in his walking. So at about 2, we said, it's not getting better. It's not in a great position. It's too far. You know that Shenton's line is disrupted on that side. The ossific nuclei is a little eccentric. And then we went to surgery. We did an arthrogram, don't worry, before we did an open reduction, and we got that in. Well, that looks pretty well covered, so we were happy. Well, a couple years later, it just, it was misbehaving. It wanted to grow a different direction. So we went in again, and this is a lot of decision making. What time of the year do you do it? What do you have to contend with? 2 other children, travel, all of those things. So he did it, and he was in his spica. And this is tough, you guys. This is really tough to recover in your spica. You got 2 brothers. You want to make sure that you can really wrestle with them. You got this cast. You can't do all your fun crafts anymore. The determination gets you where you need to be. And if you want to get up and start walking again, because this is what you do best, you do it. And I'm going to do it.
That's amazing. Get that foot all the way flat. There you go.
Okay, but wait for it. Okay, he made it. Oh, yeah. So sometimes it takes a lot of love and determination, but sometimes it's the kid, and I know that he is the dancer, and there is a balance between mobility and stability. How long we keep them in their casts afterwards. Each tissue responds a little differently to surgery, but that was him after surgery. He's doing really great. I'm so sorry, I'm over. But this is the dreaded complication that we're trying, besides dislocation again, that we're trying to avoid. And that's with all that, when you hear the words femoral shortening, it's not a bad thing. It can give a limb length discrepancy, but if it saves your hip, that is important, okay? This is I'm just going to make this point. This is a growing rod. This helps his spine grow taller. This is now moved from a growing rod to a more a permanent rod with a fusion of the spine. But you can see we're still pitched really forward. So he has pretty significant hip flexion contractures, so much so that they sent him to me for an equalization of his limbs. But in this x-ray, although this leg looks shorter, it's because it's bent. These legs, when I did a CT scan, are exactly the same. The pelvic obliquity, because he has a funny takeoff at the spine, is what was causing it. So I thought I was going to do a limb shortening or a limb lengthening. I ended up just releasing all the soft tissues to allow that leg to straighten up, and he's going to have to go back with the spine surgeon. Very scary surgery right there, but sometimes you have to step back, look up top, make sure that and the same thing, that you have to look down in the feet, and you have to look at the knees. What do you have? What do you own? And this is looking at from the bottom up. I can do some rotational profiles to assess these things. I look at a lot of things before we do surgery. And then we derotated his foot because his leg was off to the side. And now he can walk pretty well. He's waiting for spine surgery. So what's in the future? Number one, we're doing some biobank stuff. I'm hoping that we will get this off the ground. We're collecting tissues from arthrogrypotic patients because I don't think that everybody is the same. And I think that some people respond with contractures and some people maintain their range of motion. I think maybe there's different ways of assessing that with physical therapy too. I think these tissues are really very special in different patients. Maybe we'll find more genetics that supports that. But until then, I'm collecting samples, and hopefully we're going to get a big grant, and hopefully I will take it out to the other centers, and we will have somebody really looking at these and we're going to get some answers. So I think it's in the biologics. I don't think it's just my surgery. There is a lot to learn, and maybe we're going to, I think more arthroplasties are happening. I think that world has come, is coming now, and we can do it earlier. So my job is not to do surgeries every year, because that's not really what makes you better. I don't want to rob your childhood. And in some cases, I don't think that doing surgery necessarily makes you better. All right, well, thank you guys so much. I'm sorry I went over.